Hello, everyone, and welcome. We're going to get started in just a moment. Unlike our other workshops, I'm not going to provide a little bit of anonymity tonight. So we'll get started in just a moment. Again, welcome. I'm so excited for this conversation. It's been in the works for a while. I had a friend who's an OB last year say we needed to do this workshop. And for those of you who don't know, my father's was a bishop. And so I believe in the Holy Spirit brought someone to us. And so now we have this wonderful, brilliant young woman. I am Marie Boone Clark, founder of Birthing the Magic Collaborative, and we are a 501c3. And our goal is to join you with brilliant people like Dr. Dyson. So thank you tonight for joining us tonight for this much needed conversation on HIV and reproductive health. We know this is a sensitive subject for some, so we want to assure you this is a judgment-free space. We will listen, we'll honor your lived experience. You can drop your questions in the Q&A. And no one will see the questions or your profile except for Dr. Dyson and myself. So I am humbled and honored to welcome Dr. Alftan Dyson. She is head of strategic medical partnerships at ViiV Healthcare, and she is a leader in advancing HIV education and equity around the world. Dr. Dyson is a life member and foundation board member of the National Pharmaceutical Association, and she chairs the American Academy of HIV Medicine's Council on Racial Equity. We are, again, so very grateful to have you with us, Dr. Dyson. And I always say that my words can never capture the passion of your work or the purpose of your work. So please share a fuller picture of all the wonderful things that you're doing, and then we are your captive audience.
Perfect. Thank you. Thank you so much. And I'm super excited to be here with everyone and share this evening about, as Maria said, a topic that I'm super passionate about. Just a little of my background. I'm an HIV specialized pharmacist and have been an HIV specialized clinician for my entire career, even a little bit before graduating pharmacy school, and then went on to do residency in HIV, and then started right out of residency practicing in a pharmacy setting that serviced people who were living with HIV and those who could benefit from something that we call PrEP, or pre-exposure prophylaxis, which is meant to prevent people from acquiring HIV. And then I went on to, work in a clinic, taking care of patients in a clinic in the South in Alabama, where I still reside. And then later moved on into working into industry at ViiV Healthcare, which is the only pharmaceutical company that's solely focused and dedicated on HIV. So creating medications for treatment and also the prevention of HIV. So that's a little bit about my background, and just I'm super passionate about, having this conversation tonight and hopefully sharing what you guys will find to be some helpful information that you can, one, learn for yourselves, but then two, take back to others as well. Because I always tell people it's super important that we not hoard the information, be gatekeepers of the information. We want to share and educate those around us as well. So, with that, I will jump into hopefully being able to share my slides here, but just give me 2 seconds to make sure I do this correctly. Usually I'm working with two screens, and today I'm working with just one. So I'm traveling today actually, to be at the Congressional Black Caucus and present and talk about HIV with the Congressional Black Caucus this week as well. So tell me, can you see my screen and my slides?
Mhm.
Perfect. Fantastic. So we'll jump right in. And so, really, what I want to do today, I think the intent, as Maria and I have talked about, is to really try and do a series different topics around sexual health and HIV, but it felt like I think we both felt that there was a need to really kind of lay a foundation, a strong foundation for us to understand why we're even having this conversation and why we should even care about what's happening with HIV in the U.S. And so this presentation is really about laying that foundation, talking about HIV in the United States, but talking about health inequities and disparities around HIV in the U.S. Just a disclosure, the information here is scientific, it's non-promotional. We're not trying to promote any particular medication or anything like that. If there are questions that come up about it, because I will talk about prevention generally, so if there are questions that come up about specific medications, we can certainly address those offline afterwards, or feel free to follow up with me on those questions. Again, scientific in nature in this program, not going to be talking about any medications. If we have specific questions, we can, refer to the PI. And then also what you'll notice sometimes here in the text of the slides is that there may be some language that's not people affirming, or um, people first language, as we call it, but that's really because we're depicting the data as it was actually reported. But you will likely hear me voice over or say it differently than what's on the slide. And that's just a nod to the fact that we want to use people affirming language, people first language. So what are our objectives? We want to differentiate really among key terms and related to health disparities, because I think oftentimes we have terms that are thrown around: disparity, inequities, equality, inequality. And so it's important for us to understand what all of those mean in the context of health, and make sure we're using those terms appropriately. Then we want to really characterize the current state of HIV and HIV prevention in the US, discuss the significance of viral suppression and transmission rates, and then conceptualize self-directed, actionable steps towards ending the HIV epidemic, because ultimately everybody has a role to play in helping to end the HIV epidemic. So jumping into some of those definitions that I talked about, laying that foundation, disparity. You can see here Webster and Cambridge English Dictionaries definition of a disparity. And so it's where you have really a noticeable, usually significant difference or dissimilarity, is Webster, is how Webster defines it. Then when we go on to talk about a health disparity, this is really the occurrence of diseases at greater levels among certain population groups more than others. So that's where then we get this term health disparity and what that means. Inequality is different than from a disparity and from inequity, right? So inequality is the difference in the distribution of health status and achievement of health outcomes. And that's really due to genetic or other factors. So that's something that can't be prevented or modified. Like, we can't change our DNA or our genetics. And so that's an inequality that is there. But when we talk about inequities, an inequity is something that is a difference in the health outcomes due to an avoidable factor, something that is unfair, unjust, that it's related to a social injustice. So that's the difference. So when we're using the terms, and as I use them throughout, it's hopefully clear what we mean when we talk about an inequity and a disparity, and the difference between inequity, disparity, and inequality. The few more definitions that I'll talk about throughout, because I want to make sure that when I say things, everybody's aware of what I mean. So sex is like your biological status, what you were assigned at birth, male, female, or intersex. Gender is really about social construct of norms, so behaviors and roles. So how someone sees their gender and their roles in society. Cisgender really describes someone whose gender identity aligns with their sex that they were assigned at birth. Transgender then is someone whose gender identity differs from their sex assigned at birth. You have folks then who are non-binary, who don't conform or to either, don't really describe themselves in either gender role. And then Hispanic is communities of Spanish origin, or who are Spanish speaking. Latino or Latina is someone who's from Latin American origins, from North Central or South America or Caribbean origin. Latinx is kind of this gender neutral way to talk about someone who's Latino or Latina. They may not, subscribe to being Latino, or which is the male version, or Latina, and so then we say Latinx. And then Latine is really also a term that was originated from, again, LGBTQIA plus gender non-binary and feminist communities to really talk about generally someone of Latino origins. And then Chicano is another one, person born in the United States of Mexican heritage. So then I promise the last set of definitions, because again, it's important for us to kind of lay that foundation. So this, I love this illustration where we're talking about the difference between equality and equity, and then even further, more justice, right? So reality right now, oftentimes for folks is you see in the reality on the left-hand side where you have someone who gets more than is needed, while others get less than is needed. And so you have this huge disparity. So we're looking at these folks who are trying to look at this. I think it's a soccer game here or football if we're in other countries. And so you've got this person who's on all of these extra tall boxes because they've been given more. Then you've got one in the middle who has been given some, but not the same as the person, who has the four boxes. And then you have the young lady down there. She's starting from behind, right? Because for whatever reason, she didn't even get anything to start with and actually was started behind, got less than, or was even things were removed or not provided to her at all. So she can't see the game at all, right? Equality means you give everybody the same box. But if people started behind, giving everybody the same box and providing equal treatment isn't always the best either. It's not always equitable. And so that's then when you shift to equity, where you provide the person who started with less more so that they can have equity across the board. And so you can see everybody can see the game in a similar fashion with the equity one. But justice, that last one, is where you remove the systemic barrier. So you see they've removed the fence. And so that's the barrier, the systemic barrier that was preventing them from even seeing the game and having to provide these extra things. And so if we remove these systemic barriers that cause this inequity that we see, then we wouldn't even have to worry about that, and that would be justice. So think about moving forward, when you hear people say equity and social justice, that's what they're talking about, removing the systemic barrier completely so that you have justice and social justice. So a population health disparity, we already talked about a health disparity. So essentially this is where we see, the difference that is on the basis of one or more health outcomes that adversely affects disadvantaged populations. And so you can see that in their health status, disparities can exist. Disease incidence, prevalence, morbidity, mortality. And then disparities can even exist within a population. For example, here you see MMSC, that's men who have sex with men, or, folks in that group. So, or you could talk about females or women, right? In that particular group, you can still see differences or disparities that exist. So disparity from white versus black, Hispanic versus white, so on and so forth. And the reasons why disparities really exist, they can be multifactorial. And so we have to really assess that and try and understand where that comes from. So health equity, though, is what we are all trying to achieve: health equity and social justice. And so that's really where we can prevent, health disparities. We have to address the social determinants of health, address any historical and contemporary injustices that have happened, and then we make sure everyone is valued equally. And if we can do that, if we can attain that, then we have the highest level of health success for all people, and that's what we're ultimately trying to achieve. So now that we have our baseline, our foundation set, let's dig into HIV specifically. And what do we see here? So what we know is that over the last decades, we've made substantial progress, right, in in the HIV space. We've got great medications, antiretroviral therapies that help people get virologically suppressed. Some folks are taking one pill once a day. Some folks are taking injectable medications for treatment that they can get those injections and not have to take pills, and they get them every 2 months or so on and so forth, and not have to take any pills. So we've made great advances in by way of treatment for HIV. We've also had an innovation biomedical intervention of PrEP, or pre-exposure prophylaxis. And that's for folks who are negative, HIV negative, who want to remain HIV negative and want to take medication to prevent prevent acquisition of HIV. So we've made great scientific advances. We've also looked at trying to identify geographic hotspots. So where is it that we see the greatest rates of new HIV diagnoses, and how can we then deploy additional resources, interventions in those areas to help drive those numbers down. But despite this, we still have about 39,000 new HIV diagnoses every year. At the end of 2023, there were 39,201 new HIV diagnoses in that year. And so we know that it's still happening and this is stabilized. But what that means typically is if we see a stabilization, that means in some groups, the rates of HIV diagnoses are going down, but in others, the rates are going up or kind of remaining flat. And where do we see that? Male to male sexual contact, particularly in Black folks, Hispanics, Latinos, American Indians, Alaska Natives, and those who live in the southern United States. And I always highlight that because oftentimes we've thought about HIV as something behavior related, like, oh, yes, we think about it for LGBTQIA plus communities, but we often don't think about women, right? Or folks who engage in heterosexual contact, right? And so that then leads us to think about geography. And geography is just as much a factor in this as anything else, as behavior is. So I always like for people to leave with at least that point, that this isn't just always about behavior. And in fact, I would argue that more so, this is about region and where you live. And if folks are in the southern United States, we see a disparity there. We see higher rates of new diagnoses and higher prevalence of HIV in the southern United States. So then I talked about their particular groups, but this is one that I always like to highlight, the Latino or Latine community, right? Where well, I've talked about other groups have had either a plateauing or a decrease in new HIV diagnoses. What we see though in the Latino community, so, and I always point this out because you could be Black, right? Latino, Hispanic is an ethnicity, whereas Black, white, those are races. And so you can have white Latino or you can have Black Latinos, right? And so it's always important to point this out that in this community, in the Latino community, we've seen an increase in new HIV diagnoses. 12% increase. So it's going in the wrong direction for this group. And so again, we have to figure out what are the things that we can do to educate, but also to provide resources to help us reverse what we're seeing here. So then I talked about how we oftentimes forget about women. We don't have a conversation about HIV for women. And so it's important that we do, and this is why. Look at what we see here for Black women, for Black females. There's a disparity in HIV for Black females. Black females have accounted for the largest share of new HIV diagnoses among females who are 13 years of age or older in 2023. They accounted for over or about 50% of all new HIV diagnoses in females. And so this is a disparity because that 50% of all new HIV diagnoses among females, but only representing 13% of the US population. And so this is a huge disparity, and you can see it on the side. 50% for Black or African American, 24% for Hispanic or Latina, and then for the white counterparts is about 22%. So Black women are experiencing the highest burden of HIV disease and new diagnoses. But not just in new diagnoses. Look at this among Black women who are living with HIV and receiving care. What you see here is that regardless of age, transmission category, where they reside, whether it's a metropolitan area, non-metropolitan, urban or rural area, there are still folks who are out of care. Like Black women are not receiving the care that they need. At about 20 to 30% of those women who are living with HIV, Black women are not receiving care. And so it's important for us to know that and have conversation with, you know, our patients or with our friends, right? Like our family members, to make sure that one, we are getting people in care and that people are getting tested, and particularly Black women and those populations or communities that are disproportionately impacted by HIV. I talked about this also a little bit where you see, I talked about geography and what's happening in some of these areas. And so all the pretty bright red, you know, if red is your favorite color, in this case, red is not meant to be a favorite color. It is really highlighting that in these areas, right? we see the greatest rates of new HIV diagnoses among persons aged 13 years or older. And so it's important to really understand that, again, this is just as much about geography and where people live, work, and play as it is any type of behavior that is associated with it. I always like to say, if we look at this and we pick out, I don't know, I live in Alabama, so we'll pick out Alabama, pretty bright red, right? So high rates of new HIV diagnoses. And so the same number of sexual partners, I can have the same number of sexual partners that I do in Alabama that I do in Montana, right? But the propensity, the chances of contracting HIV and new diagnoses of HIV is just higher in Alabama because the prevalence is higher. It's a numbers game. If there's 100 people here and only 5 people here, I'm likely to come in contact with somebody. The likelihood of coming in contact with somebody and the propensity for or chances for acquisition is just higher in Alabama because the sheer number is higher. And so that's what I say about geography as it is anything else. Just quickly, also looking at this is also true for the disproportionate impact in people of trans experience or trans people of color. And so here you can see Black and Hispanic and Latina transgender women represented 83% of transgender women living with HIV and 89% of all new HIV diagnoses in that particular group of folks. And so again, this is what it's highlighting again over and over again that you'll see is that this is particularly a disease state that is disproportionately impacting people of color, right? Black, Hispanic, Latina, and then folks who are living in certain geographical areas. And so this is again showing that that color here where you see the geography, that geographies that are most impacted here. And you start to see some others start to light up when we talk about all here where you see, uh-oh, I have lost the slides. They went away. I don't know what happened. Okay, here we go. Where you see California and Nevada starting to light up here. Another thing that's often not talked about enough, I think, is the fact that at the end of 2022, about 54% of all people living with HIV were
Oh no, Dr. Dyson has frozen. Let's hope her connection gets better soon. While she's doing that, reactions in the are we tracking with her? Um, Dr. Dyson, if you can hear me, you're frozen on my end, or our end rather. Ah,
my
there you
bad.
go.
Okay, it's the internet at the hotel.
They'll do it to you.
They'll do it every time. Let's see. Here we go. There we go. My screen's showing again. Yes, perfect. So it's talking about the aging population and how HIV is now
Oh no, it's happened again. Let's hope she can get a better connection. That first stat for someone who's over 50, but thankfully I'm in a committed relationship of like 53%. We're 50 and over. So age is not protective. Ah, you're
okay.
back.
I'm back. Just give me 2 seconds. I'm going to do something else. I'm going to use my hotspot on my phone. I am not going to trust them.
I was talking amongst ourselves like 50 and over. Clutch my pearls. Ah, there we go. I think we heard
Okay.
you. Yes.
Perfect. I have my hotspot on my phone now, so hopefully that will work and we won't have any more issues. I apologize. Okay, so I've talked throughout a little bit. Okay, am I here? I think so. Okay. So I talked about the geography, but I wanted folks to really be able to see specifically what areas are we talking about. And so in the Ending the Epidemic Plan, that's what it's called, it's a EHE or Ending the Epidemic Plan. I talked about how we identify particular geographic areas that have the highest burden of HIV. And so 48 counties throughout the United States, 7 states, like the entire state, and then 2 cities were identified as having this high substantial HIV burden in their areas. And so I won't ask for a show of hands or anything, but I'd ask people to look at this list of counties, look at the states there in the lower right-hand corner, all in red, and the 2 cities, Washington, D.C. and San Juan, Puerto Rico, and tell me, think about in your mind if you live in one of these areas. And if you do, if you live in one of these areas, or if you're a clinician and practice in one of these areas, have family in one of these areas, these are the areas that have the highest HIV burden, and where we really need to have good conversations with folks about the need for HIV testing, the need to know their options around prevention, and if folks are living with HIV, being in care and staying in care to be virologically suppressed, because these are the areas where we know there's the highest disease burden. And so then I look at the military. And so we threw this in because people are like, well, why would we throw this in here? And it's because the military actually did something as well. And it's really to drive home the point around geography. And that some of this is just about that. Because one thing that happens with the military is that they all have insurance, right? So access shouldn't be an issue. And so when people say, well, access is what's driving the problem, like access is the reason we see the disparity, that's not necessarily maybe the case in all situations, because when we look here in the military, again, a group who has access to services, they looked at service members who were diagnosed with HIV, and they wanted to understand what was the makeup. And 96% of them were male, and I think that's probably indicative of the fact that there's a lot, probably a higher rate of males in the military. But look at this, 74% of them were non-Hispanic Black. So again, highlighting that this is a disease state that's disproportionately impacting communities of color, because then right under that, you see a tenfold increase for Hispanic males. So this is the increase in new HIV diagnoses in those folks. Again, communities of color. And then they do get tested somewhat regularly every 2 years. And so that's not necessarily the issue either. When they looked again at this study, because they look at this a couple times, you look at the one on the right, they were looking then at this Army cohort, and again, trying to identify the factors. Again, male, predominantly 59% Black. But I talked about this earlier. 64% of the folks in this arm were stationed at some point in the South. 64%. It wasn't that they were from the South, they didn't live there. They just were stationed in a southern region at some point. So this really drives home the point again that geography is a big factor in this versus anything else, right? Versus behavior. Geographically, if you're in an area where there's high prevalence, the chances of coming in contact with or the chances for transmission of HIV are just higher, and particularly in the southern region, which accounts for I don't know if I said it, which accounts for about 52% of new HIV diagnoses every year. And so that's what this is showing. I just said it, 52% of new HIV diagnoses, and this was in 2018. Spoiler alert, it hasn't changed. It's still 52% at the end of 2023 of all new HIV diagnoses occurring in the US South. And a lot of what drives that too is rural the ruralness of the South, right? So you see Alabama there, 67%. That's how many people, particularly Black folks, who live in a rural, outside of an urban area or in a rural area. So that also plays into it, because the rurality means that when you're trying to access services, often it's difficult to access those services if you're in a rural area. And so this is also another reason why we have to think about this and think about geography and not just behavior, right? So why is this a disparity that we're seeing what we're seeing in the South, and why would we call it that? Well, the South really only accounts for, and this is just census data, this of the distribution of the US population. The South only accounts for about 39% of all people who live in the United States, but account for about 52%, as I said, of all new HIV diagnoses. So that's a disparity in itself. The fact that you're seeing um, higher rates of HIV prevalence and new diagnoses in the South. The other thing that we see is the lifetime risk of an HIV diagnosis. If you're in one of these red areas again, the lifetime risk of acquiring HIV or having an HIV diagnosis is much higher than it is for any of the light red or the light blue areas. Even that darker blue is a little bit higher, is quite a bit higher chances lifetime risk of acquiring an HIV diagnosis. This is again looking at some specific areas, and so driving in persons living with diagnosed HIV and kind of the prevalence there. So you can see the darker blue and the darker red. That's where we see the higher rates of HIV, and people who are living with HIV, diagnosed HIV, is in those areas. So again, those southern states are really coming in quite high at the prevalence. And so that goes back to, again, my conversation earlier about this is as much about geography as anything else. Because if the prevalence is higher there, that means you have more people living with HIV in this area, then that's just a larger population there, and the chances of coming in contact with someone who's living with HIV are just higher. So viral suppression, and we'll talk about this a bit, because what one thing that we know about viral suppression is that we want to get people who are living with HIV diagnosed. So that test is so important. Everybody being tested is so important to know your status. And then for those folks who are whose their test comes back positive and are living with HIV, we want to get folks into care, and we want to get them on medication and treatment, because what we know is that if we diagnose someone, get them on treatment, we can then drive their viral load down to achieve viral suppression, and they cannot transmit HIV to any sexual partners. So I'll say that again. We call it U equals U. Undetectable equals untransmittable. So if someone who's living with HIV is on medication, in care, and virologically suppressed, they cannot transmit HIV. And so this is important. Countries look at this. And so what you're looking at here is comparison against other high income countries and their HIV viral suppression rates. And we know we always talk about the US. The US is like one of the most resourced countries. We do everything well, right? We're supposed to be fantastic. But yet when we look at all of these high income countries where the US stacks up, we're only 67% virologic suppression. Whereas we look at the United Kingdom, they're 92%. So we've got a lot of work to do in the US, right? To be a high income country like these others, we're lagging behind. And so what drives that a little bit? I think it's the testing. I've said it. And so it's important. And I would say for you all to think about it again. We don't have to, out yourself or say anything or drop anything in the chat, but think about the last time you went to the doctor. And if your prescriber, or I mean, your provider offered you an HIV test or raised the conversation with you, ask the question. I usually, even with my folks, I usually have to ask for it. And you have to ask them, are you going to ask me if I want an HIV test? And that's a problem, because you can see, and it's a problem throughout the country. What you see here is that overall, people having ever been asked or ever been tested for HIV is only 36%. When we look at Black folks, it's only 57%. And so that still leaves quite a bit of folks who don't know their HIV status. And that'll be important as I move forward in a few slides. slides here. So when we look at then how does HIV transmission occur, right? How do we see these new diagnoses? So the percent of people who are living with HIV who are unaware that they have HIV, so that's 13% of people who are living with HIV but don't know it because they haven't had the test to know that they're living with HIV. They account for 46, almost 46% of new transmissions. So this right here alone should tell you why it's important for everyone to be tested. Because if you're living with HIV and you don't know that you're living with HIV, that transmission, those transmission rates are high. And that makes sense, right? Because you don't know, and I don't think that people are intentionally out here, trying to have transmission of HIV, but they don't know, and nobody ever asked them to get a test, and they haven't been tested, so they just don't know. The other area where we see it's high and almost as high is people who are aware, but they're not connected to care. So if we go back and think about that slide that it showed for Black women and how there was about 20 to 30% of Black women who were living with HIV but weren't connected to care for whatever reason. Maybe it's an access issue, maybe it's stigma. Right? Maybe it's just the stigma of the disease state, because we all know that HIV carries this huge burden of stigma. And you'll often hear a lot of us in the HIV community as providers say, and even folks who are living with HIV and those who are on PrEP say that HIV doesn't kill people, stigma does. Because stigma will keep someone from going to seek care. Stigma will keep someone from engaging in being on a prevention option. And it's time out for that because we have the tools to end the HIV epidemic. We have medications for folks who are living with HIV who can live and thrive with HIV, and we have medications to prevent HIV. But if we don't get people in because of stigma or whatever other reasons, then that's what is driving this epidemic, and that's what's causing people to lose their lives. So then when we look at this, there are some areas that are getting it right. So this is the US again. And so we have these goals that we say 90, 90, 90. So what we want is 90% of folks who are living with HIV to know their status and to receive care. We want folks to be retained in care, and then we want 90% of those folks to then be virologically suppressed. We're at 76% here when we looked at this at 2023, 76% who've received some HIV care, but some doesn't mean that they were retained. Only about 55% of those were retained in care, and then of that 55%, only 67% of those were virologically suppressed. So we have a long way to go. But I said there are some areas that get it right. Ryan White clinics. So if you have been around long enough, the young boy back in the late 80s, early 90s, Ryan White, who the CARE Act is named after, that young man, he acquired HIV through a blood transfusion. And so we have a federal program, the Ryan White program, that takes care of people who are living with HIV. And so in this case, the Ryan White clinics and folks, the clinics that receive this federal funding, Ryan White funding, they have 91% of their folks who are virologically suppressed. So this tells us that that program works, right? And they have a lot of wraparound services. They do a lot of things to address social determinants of health or social drivers of health. And so this is just a nod to that program and how that program works. And it's a federally funded program, and it works. So I also talked about, I was talking about these 90, 90, 90 goals and the targets. So we look here at some African nations, nations that were funded by PEPFAR, right? And we know what's happened here recently around PEPFAR funding, but this is prior to that. And so they also were trying to achieve these 90, 90, 90 goals. And what you see here is these low middle income countries is what we call them: Malawi, Zambia, Tanzania, Zimbabwe, Namibia, Ethiopia, Kenya, Rwanda. They're close to achieving this 90, 90, 90, or in some cases have achieved it, in particular for folks over the age of 50. The United States, 65%. We're not even close to the 90, 90, 90. And so again, as a high resource country, right, high income country, We're not able to achieve this 90-90-90 where these low middle income countries have been able to do it. And so that means we've got work to do. And there's something to that. There's something else we need to do and have conversations and come together to figure out what are we doing not so well? How do we get better? What are our opportunities for improvement? This just again illustrates that again, and we see this actually across the board that again the red is black folks, and so again these are folks who are not getting virologically suppressed, who are not in care, and so we see a disparity there as well. Again, we look at viral suppression by areas of the country. The purple is the South. I talked about it. It's 69.3%, and the West is 69.2%. So again, this is about geography as much as it is anything else, as much as it is behavior. And when we look at Black folks compared to other folks, lagging behind in viral suppression again. So I've talked a lot about kind of the data and like what the epidemic looks like. I want to switch gears here now and talk about uh, I talked about pre-exposure prophylaxis or medication that can be taken to prevent HIV. And I think it's so important that we always include this in the conversation because not many people know about pre-exposure prophylaxis. Looking at some data the other day and did a presentation yesterday that was specifically focused on Black women and women. And actually what we learned was that only about 20 to 30% of women, cisgender women, women who were assigned female at birth, uh, knew about PrEP. And that is just not acceptable in this day and age. We've had a HIV prevention option, some option, available on the market for over 13 years. Since 2012, we've had HIV pre-exposure prophylaxis medication available. And to say that only 20 to 30% of women knew that it existed is to me a travesty. I don't know how other people feel, but that's what I think. And then when we look at how many have actually used PrEP, only 8%. So in all of these 13 years, we've gotten this far and only 8% of women, females, have used PrEP. And so here it is, talking about the PrEP coverage, who's using PrEP. So again, the darker red and the darker blue means we have work to do. That means that those areas have a high, what we call PrEP to need ratio, or low in this case, because the higher the number, you see here, the Northeast region at 22, they have the highest PrEP to need ratio. That means they're doing better than everybody else compared with the South. The South has 10 PrEP to need ratio. So that means we are seeing more or higher new HIV diagnoses than we do see PrEP usage. So for example, there in the South, talked about it, 52% of new HIV diagnoses occurring in the South, but only 38% of the PrEP users are in the South. I mean, this to me is a no-brainer. If we get people on PrEP, we should be able to see a decrease in the number of new HIV diagnoses. And so we've seen progress right here. That's what you're seeing here, this kind of trending up. It's a slow trend, tick up of folks getting PrEP and receiving the benefits of being on PrEP. But it's still slow increase, right? And we've seen, increases in the 57 ending the epidemic jurisdictions, but again, there are inequalities and gaps in coverage that remain, and that's what you're seeing here. So in 2012, I said that's when we got the first PrEP medication. You can see it's not as lit up. We've had a greater than 4,000% increase at now 26%, 27% of folks using PrEP. But that's not enough, right? Because we're still seeing that 39,000 new HIV diagnoses every year. And we look over at the South, it's pretty sparse at being dark over there, right? The South is not picking up and using this PrEP. When we look at it by people, by demographic groups, Black people, here it is. At the end of 2024, they accounted for 15% of PrEP users, but 38% of new HIV diagnoses. Latinx, Hispanic population, 18% of PrEP users, 32% of new HIV diagnoses. But white people, you see 63% PrEP users and only 24% new HIV diagnoses. So this shows, if nothing else, it shows there's a disparity, but it also shows that if you use PrEP, i.e. 63% using PrEP, 24% of the new HIV diagnoses. So if you use PrEP, you have less HIV diagnoses. And so we've got to flip this around also for Black folks and Hispanic and Latinx people. Um, and we have data that supports that, right? So there were 10 states with the highest average levels of PrEP coverage, meaning they had people using PrEP. They saw a 38% decrease in their new HIV diagnoses. Whereas the 10 states with the lowest PrEP coverage, they had a 27% increase in new HIV diagnoses. So we've got to get folks using PrEP. We have to get folks aware and knowing that PrEP is an option and is available. Because when we use PrEP, as we can see here, in those states that had the highest PrEP coverage, they saw substantial decrease in new HIV diagnoses, and the ones who didn't use PrEP had an increase in new HIV diagnoses. This is also, the CDC always kind of looks at who should be using PrEP, right? And they said they estimate that actually the number of PrEP users that we should have, or people who could benefit from PrEP, is right down here. Let me see if I can, I don't want to touch anything because I don't want to mess it up. I was going to get a laser pointer, but right down at the bottom, you see the total. They say about 2.2, somewhere between 2.2 and 2.5 million people in the US could benefit from PrEP. Okay. But we don't have nearly that many people on PrEP. You saw that on the prior slides. But they're saying this is the number that we need, that number needed to treat to make sure that we could drive down these new HIV diagnoses and effectively in the HIV epidemic. What's also interesting about this is we always, again, I said this early, folks associate this with the LGBTQIA plus community. But if you look here at this male to male kind of sexual contact here, they say 492,000 people is males who could benefit. But if you come down here, it's 468,000 women. So that's basically the same almost number of women that they estimate could benefit from PrEP as it is male to male sexual contact. So we have to stop thinking about this as just a particular group of people who could benefit, because the CDC is very clear that we also need it just as much in women and in men who are heterosexually active as well. I've already talked about the inequities in PrEP, but I think this slide is here and it's important. This is the PrEP to need ratio. So again, that PrEP to need ratio, the way we get it is we look at the number of new diagnoses that occur every year and divide that by the number of folks on PrEP. And the lower the number, the worse off we are. And Black folks are at 5.9, Hispanic 8.7, and white folks are at 40.8. So this alone, this snapshot alone to me speaks volumes that there is a disparity here, there's inequities in PrEP utilization, and we have to address this if we want to end the HIV epidemic. And this is again kind of showing that trend again. The PrEP usage looks more like the US Census and the population than it does the people who are actually living with HIV and the people who could benefit from PrEP, right? So we see here, this is the US Census, 58% of folks are white, and they account for 28% of the folks living with HIV, but their PrEP usage over here on the right-hand side, PrEP coverage trends is much higher at 94 versus Black folks at 13 and Hispanic or Latino at 24. Also the PrEP coverage by gender and age. So we see the majority of PrEP users being males. But we talked about that there is a need for women to use PrEP. Only 9% of women are PrEP users, despite representing 19% of new HIV diagnoses. This is again a disparity and showing that there is work that needs to be done to make sure that we address these inequities. And we also need to make sure that we're getting people age 13 to 24 to know about PrEP and to be on PrEP, because they account for quite a bit of the new HIV diagnoses in that age group, anywhere really between 13 and 34. Those folks need to be using PrEP. Okay. Um, and this is then, I mean, I can tell the story a million different ways, right? So Black individuals have higher unmet need than white or Hispanics when it comes to PrEP coverage, and that's regardless of where you live in the country. So whether it's in the Midwest, the Northeast, the South, or the West, we see there is a huge disparity in equity in PrEP usage by communities of color. There are some states that really need some PrEP coverage and need more education around PrEP. And again, it's particularly in the South. They account for new HIV diagnoses, so it makes sense that we would need those folks in the US South to be aware of PrEP, know that as an option, and be able to have access to PrEP. Because that bright red, as I've mentioned before, and even the light pink here, these are areas where we're really lagging behind and need to have better PrEP coverage and utilization. Um, so some interesting additional facts, kind of fast facts about PrEP. This one blows my mind. So there were 46,000 people who were screened for PrEP in the first half of 2023, and only 2,000 of them actually got a PrEP prescription. So I'm trying to figure out what happened here. So we were on the right track. We were having a conversation about it, but out of 46,000, only 2,000 people got the PrEP medication prescribed. So use isn't always really aligned with the at-risk population due to some barriers. And we have to talk about those barriers. We have to be honest about what those barriers are. Again, I talked about stigma, could be awareness. People just don't know. We've talked about that as well. That folks just aren't aware that PrEP exists and is available for anyone, right? All sexually active adults is what the CDC says that we should have, who we should have a conversation about PrEP with. Um, also looking at funding and expansion of services and also then Medicaid. So in those areas, the 57 ending the epidemic jurisdictions where they had funded and put some of that resource in, we did see uptake in HIV testing and prevention services. And so we have to continue to put those resources in areas that really need it. And then expansion of Medicaid. In those states that actually expanded their Medicaid programs, you saw 1.4 times higher PrEP usage rates than those states that didn't expand Medicaid. And so again, it's that access piece, making sure that people can access the medication in addition to being aware of this as an option. So again, barriers and strategies. I think this is where we're rounding second base coming to, or rounding third base coming home. Um, it's not always about access. And so I usually love to have this conversation with clinicians as well, because I say, as a clinician, I can say we're sometimes the barrier. Hopefully, I don't offend any clinicians who are on, because we have to be comfortable having conversations about sex. And a lot of people just aren't, and they're not comfortable talking about HIV and recommending an HIV test. But it should be a part of routine care. I always say sexual health is a part of whole person health care, right? I said yesterday in a program where I did a talk, I said, we either A, have thought about having sex, want to have sex, or have had sex, or plan on having sex. All human beings are in one of those categories. And so, why it is uncomfortable for people to have conversations and clinicians to have conversations about sex is beyond me, but we have to normalize that conversation, and we have to make it a part of routine care if we're going to get to a place where we can end the HIV epidemic. And so these are just some barriers, right, to testing. Age differences. Age is not a barometer for sexual health and wellness. I can't say that enough, because if I hear one more time, well, she's old enough to be like my grandmother, I don't think she's having sex. Okay, that then does not explain why we see an increase or a rise in STIs in nursing homes and assisted living facilities. Somebody's having sex in there. So age is not a barometer for having a conversation about sexual health and wellness. We just need to get that out of our mind. Um, Unsure about how to initiate the discussion. If we make it routine, it'll be comfortable. This unsure about how to initiate the discussion is really about discomfort. But if we make it a routine part of care and a part of our conversations, as clinicians, but also as patients, being comfortable having the conversation with clinicians, then we'll be able to know how to initiate the discussion. It's really just talking about it. How's your sex life? Is there anything that we need to discuss? Is there anything that is uncomfortable or things that you have concerns about? Is your sex life the way you would envision it to be? It's very simple to initiate the conversation. Um, Feeling like patients would refuse the HIV test. This one always gets me because HIV testing is actually an opt-out test, just like any other test. And so I say, we don't go in, or clinicians don't go into the room and say, hey, I'm going to get your A1C today. Is that okay with you? They don't ask that. They don't ask you, is it okay to get like a CBC or CMP panel? We don't go into all of that. We are trusted folks, trusted messengers who should do what's right for the patient. And if we know that we are in a geographic area that has a high prevalence of HIV, this should just be a part of the conversation. Hey, I'm doing all the things, I'm getting all the tests that I think are necessary based on what I know about you, but what I know about the area that we're in. And then that should be a simple conversation that we should do. So I talked about the CDC and that they recommend, here it is, discussing PrEP with all sexually active individuals. Hard stop. That's it. Someone who's sexually active, you have a conversation about PrEP with them. They do say that there are some folks who would benefit even more from having the conversation, but they are very clear that all sexually active individuals should have a conversation about PrEP and be aware of PrEP. Some groups, though, that they do point out and say they may benefit from PrEP a little bit more is those with sexual partners who are living with HIV and not virologically suppressed. So that goes back to the conversation I had before about U equals U. If someone's living with HIV, virologically suppressed, they can't transmit HIV to their sexual partner. But if they're not virologically suppressed and their partner knows that they're not virologically suppressed or is unsure, it's worth having a conversation about PrEP. Folks or the second one or third one, members of groups or communities with high HIV prevalence. Well, I just said that the South is a geographic HIV hotspot. Some other counties, I showed you the 48 counties, the 7 states, the 2 cities. Based on CDC guidelines, those are folks who could really benefit from a conversation about PrEP and an HIV test. People who request PrEP. This one always gets me. Somebody goes into their provider's office and says, hey, I'd like to have PrEP, then do not try to discourage them because they have already assessed their own vulnerability to HIV and they've decided that it's right for them. So unless there's a good clinical reason that they can't have it, they should get it. They should be allowed to have PrEP because they know that they need it. They've assessed that situation. Down, if we look at endorsing behaviors, bacterial STIs within the past 6 months. If someone has been diagnosed with an STI, what we know about STIs is that they run together. And so we need to make sure that we have a conversation about PrEP because undoubtedly, I can't tell you how many times that I've treated patients for an STI and at the time we didn't have the option of PrEP and shortly after they come back and we're having a conversation now about an HIV diagnosis because they run together, those STIs. And so I've already talked about some of this data here. Only 15% of women who could benefit from PrEP were prescribed it. And then studies show that only 20 to 30% of women are aware of PrEP. The other thing I always kind of around this when we talk about barriers is the shortage of clinicians. So for forever, we have always had HIV specialists, right? I said that when I started. I said, I'm an HIV specialist. That's what I do. But there's a shortage of us at this point. There is a decline in the number of HIV providers, and we have to get other providers on board, be it women's health providers like OBGYNs, midwives, doulas, primary care providers, you name it. everybody now needs to have this conversation, because if you're expecting HIV specialists to carry both taking care of folks who are living with HIV and make sure people who could benefit from PrEP get PrEP, it's not a realistic expectation because there's just not enough of us. So everybody has to contribute to this. Everybody has to come on board, right? And even across disciplines, we need nurse practitioners, we need PAs, we need doulas, we need midwives, we need everybody. It is all hands on deck at this point to have this conversation to make sure that we can decrease this burden of HIV in the United States. So how do we have conversations? How do you do this, right? I said it's all hands on deck. Everybody should have this conversation. How do we do it? Simple. The way we discuss sexual health and PrEP, stigma free, right? We create a patient centered, non stigmatizing environment. And we're just here to share information and empower patients to make the best decisions for themselves, right? We want to reduce any barriers that we can, but we normalize this conversation. We make this a part of routine care and non-discriminatory healthcare. That's what we need. Everybody who could benefit should have this conversation. And I think about it in a way that if we want equitable healthcare for all people, then we have a blanketed conversation, a normalized conversation with all individuals. And so the CDC has come out with these 6 Ps. It's partners, practices, protection from STIs and HIV, past history of STIs, pregnancy intentions, and then they have another one that is pleasure, right? And so a lot of times people say, oh, pleasure. I'm not sure I want to talk to my doctor about pleasure. Or even clinicians say, I'm not sure I should know about if somebody finds their sex life to be pleasurable. It's like, well, why not? Because what if it's not pleasurable? It could be that they're in an intimate partner violence situation. And so sex isn't pleasurable because they don't have the opportunity to say no or to negotiate or to, not be involved. And so it's not a pleasurable experience. And if we don't ask that question, we won't find that out and we won't be able to then help them in turn, right? Because we want to be able to help in that situation. It could just be that someone is aging. I talked about the number of people living with HIV being that are over the age of 50. The majority of folks are over the age of 50. How about as we get older as women, there's vaginal dryness, right? And that friction can be uncomfortable. But if we don't have the conversation, we can't help someone in that situation. We might need to be talking about some estrogen supplements or whatever it is to address that. So that's where that pleasure piece is important, right? It's not because you're trying to be in somebody's business or somebody's trying to be in your business about who you do it with, how you do it, where you do it. There are some real medical, clinical reasons that we would want to know if sex is pleasurable. Um, some other things that we have to think about as barriers, societal, social, policy, or structural determinants of health, particularly when we think about the South. The South has the highest rates of poverty and lowest median household incomes compared with other regions across the country. And so those social determinants or social drivers of health really can contribute and drive these higher rates of HIV that we see in the South. So again, not necessarily about a behavior. It's about where they live, and it's about the fact that there's higher rates of poverty, lower household income, and so there's some social drivers that drive these higher rates of HIV. Some fast facts: 56% of Black Americans live in the Southern region. So if I said that this is a disease state that disproportionately impacts Black folks or people of color, and then it's the South, this is like the perfect storm, right? Because it's Black folks in the South. We have to have this conversation. Um, you know, I talked about there's only 38% of the population is in the South, but 52% of the new HIV diagnoses. 14% of people living with HIV in the South were unaware of their HIV status. And I showed you on that previous slide that group of folks who are unaware of their HIV status account for about 47% of new HIV diagnoses every year. So we've got to have some conversations about geography and not about folks' behavior. Some other things here, these social, political, structural determinants of health, I talked about it: stigma, poverty, STIs, bias. We got to check our biases at the door. because this is not about me agreeing with what you do or how you do it. This is me taking care of people, right? As a clinician, that's what I signed up to do. I signed up to take care of my community and take care of people. And that's what I need to focus on. And if I know that this is a particular uh, disease state that is impacting that community and is having where they're having those issues, then I need to be okay having those conversations and check my biases at the door. The fear, we've got to get rid of the fear. And the way we do that is normalizing these conversations. So last slide here, some programs just to be aware of. The CDC has this Take Me Together, Take Me Home. So you can get a self HIV test at home. And it was quite successful. You can see here, March 2023 to March 2024, they distributed almost 500,000 HIV tests to over 219,000 people. 7% were currently using PrEP. 2% had received an HIV diagnosis. And so we see this as being a successful program. It had been discontinued at the end of April of 2020 of this year because of the funding cuts and the layoffs and things from the CDC. However, we heard just last week that they were able to restore some of those funds and be able to restore this program. So super excited about that. And so I say, tell people about this. Folks, again, that stigma, that fear of the HIV test and getting it or asking about it, this is a way to do it at home. You can get the test, they ship it to your house. You can take the test yourself at home and know your results and be able to mail in some cases, mail it in and get your results anonymously. So this is something to make sure that people are aware of, to be empowered, to be able to make decisions. So this is my last slide. It's a call to action, right? I've talked about some data here, some things that are not. I don't think any of us would be excited to see some of these data points. But what I can come here and say is that we have something that we can do. All of us do, right? You may not be a clinician, but you know somebody who could use this information. You have friends, you have aunts, you have sisters, you have brothers, you have cousins. Um, just a little anecdote about myself. You see, I'm passionate about this topic. And so I fly a lot. Don't sit next to me on the airplane and then start chatting me up and asking me what I do for a living, because honey, you're going to hear about what I do for a living. And by the time it's over, you're going to know about PrEP. You're going to know about getting an HIV test. You're going to know all the things. I bought a house recently, not too long ago, maybe 5 or so years ago. I used the same mortgage company and the same guy who was my mortgage person. And he said, Doc, remind me what it is you do again. Because, they get all in your business when you buy a house, right? They need all your W-2s, they need all your information. And he's like, you changed jobs. This is a different company. I said, yeah, yeah. And he said, remind me, what do you do? I said, oh, I'm an HIV clinician. He's like, HIV, that's still a thing? I said, yes, to the tune of 39,000 new HIV diagnoses every year. And let me tell you something. So then he got all of the statistics. And then what was interesting, I told him about, U equals U. And he said, I didn't know that. That's interesting. Why don't people know that? I said, well, if that's something, I have something that'll really blow your mind. What if I tell you that there's a prevention medications that you can take? And he said, what? And he went through, but what was interesting, he went through all of the range of emotions. He was shocked, but then he was sad, and then he was mad. Because he said, why doesn't anybody talk to us about this? Why doesn't anybody provide this information to us? Why doesn't anybody ask us to get an HIV test if they know that this is a problem? And so that's my challenge for you all. Don't keep the information to yourself. Share it with other people, because people get upset when they know that we know something and we haven't shared it. And especially when I've seen women in particular come into clinic and be diagnosed with HIV and tell me, I've been going to the doctor every year for my yearly, for my annual. What do you mean I didn't get an HIV test? What do you mean they didn't know? I should have known. I went there expecting that they were going to take care of me and offer me everything that they thought would be helpful for me. And that's a very sad place to be in as a clinician, to be on that receiving end, to have to say that, yes, you are right. Someone should have had this conversation with you, because we could have prevented you getting to this point. into this place. So that's my challenge for everybody today. That's my call to action for everybody, is have the conversation with somebody. Go and talk to one, two other people today after this and share the information and encourage people to get tested, know their status, right? And if, it never hurts to know about PrEP. They may not want PrEP, but they might know somebody else who does want PrEP. So with that, these are the conclusions. I think hopefully you got them. You can read them here. And I will yield my time back to Miss Marie to see if there are any questions or comments.
Oh, thank you, Dr. Dyson. I hope we've got lots of conversation in the chat. The first question is, can you tell us what is PrEP? Is it an injection? Is it a pill? Do I take it every day? Is it what exactly is the product?
Sure, perfect.
Or
That's a great question. So PrEP is it's pre-exposure prophylaxis is what it means. And it's medication, right, that we can take to prevent HIV. We have different options. So we've got 2 oral pills, 2 injectable options on the market. So you can take orals, and it depends on who we're talking about. So there's 2 oral options. One is available for anyone who would like to take PrEP, meaning men, women, so folks who were assigned female at birth, some folks who were assigned male at birth. There's another oral option that is only available for those folks who were assigned male at birth, right? And that's just because that's how it was studied. So we only have data in that population. So when the FDA approved the medication, they only approved it for folks who were assigned male at birth, not female, right? Then in terms of the 2 injectable options, you have one that can be taken every 2 months, one that can be taken every 6 months. Both of those are available for anyone who would like to receive PrEP, so male or female assigned at birth. Does that answer the question?
it does. It does. And I'm going to drop that in the chat, guys, for you all. The next question, the prevailing question is, will these slides be available, or are there excerpts that you can make available for us to send out?
Sure, absolutely. So if you can collect and let me know, Marie, which slides were most important or impactful that people wanted to have copies of, then I can make the request internally to make sure that we could get those.
Okay, thank you. And then
Mhm.
just to clarify that as a doula, I can still have this because as a doula, I don't provide medical care, but I do talk to my clients, right, about what they should expect when they see a practitioner. It would be acceptable for me as a doula to tell mom or the expectant parent, if you should be prepared for them to offer this test, and if they don't, you should ask for it, right?
Absolutely, absolutely, 100%. So, I always tell folks that, especially for moms or folks who are expecting, the guidelines recommend a pregnancy. I mean, a HIV test at the beginning, right, of pregnancy, and one in the 3rd trimester. So do not forget that one in the 3rd trimester. And it's that is the recommendation, and many places have gotten to a point where in some places it's like required. You must do it. And so if somebody doesn't offer it to your clients, your patients that you take care of, make sure that they get it done, because I can't also stress enough how many times, even in clinic, where I would see women who were pregnant who would come in and didn't get that 3rd trimester test, or they did, and it came back positive. That first one at the beginning of pregnancy was negative. 3rd
Mm.
trimester one is positive, and now we're racing trying to make sure that we can get them on medication, because if we can get a mom on medication and get her virologically suppressed prior to delivery, then she can have a vaginal delivery. Cesarean is not required and not necessary. She can have vaginal delivery, and we can make sure that the baby doesn't have HIV, doesn't acquire HIV from mom. So it's very important. That 3rd trimester test is so important as well, because that is a prime window for us to make sure that we get mom on meds to prevent transmission of HIV to the baby.
That's a big point. And so one of the things that you said when I met you in Chicago, that really struck me is some people have the assumption is, oh, I can live with HIV. There's a treatment, and you pointed out something that I think would be scary for most of us. Would you repeat that about like diabetes and high blood pressure and what it does to our bodies or what have you?
Absolutely. Yeah, I remember us having this conversation, and I got so uncomfortable and nervous when you said that people say, "Oh, well, HIV is just another chronic illness. I can live with it. It's fine if I get diagnosed with HIV." And so there's some truth to this, right? That yes, we do treat it now as a chronic illness because, as I mentioned, the majority of people living with HIV now are over the age of 50. And that's because we've had great advances in medication. However, what we also know is that HIV is an inflammatory process, right? And it, even in folks who have achieved viral suppression, right, are on meds, managing HIV well, even in that population of folks, there's still this inflammatory process that's happening in the body that then accelerates the aging process. And so that means it's impacting the other organ systems. And so we often see that those folks are at an increased risk of developing high blood pressure earlier. They develop diabetes earlier, they have complications earlier. I remember one of my patients diagnosed in her 20s. By the time she got to about 30, 35, she had had her first heart attack. That's not normal. We don't normally see that in folks that young, right? That's not something you think about for someone that young. But what we know is that HIV exacerbates those other conditions. And so, yes, you can live with HIV, you can be on medication, you can be biologically suppressed, but it's not benign. And it's not like we've taken care of everything else that HIV causes. So I would caution people thinking about it in that way that, oh, it's okay if I get HIV. It's not, right? And why would we want to do that when we can absolutely prevent HIV with prevention medications?
Thank you.
Yep.
We have a ton of other questions, but I know we are short on time. We'd like to invite you back for phase two. I've already talked a little bit with Dr. Dyson about doing part 2 and 3 and 4, and maybe once a quarter, spending some time on this because I think it's critically important, or we know that it's critically important. I think the heartbreaking thing for me was when I learned, I had the chance to attend Dr. Dyson's section at the NMA, and to hear, because I was around with Bristol Myers with young Ryan White, and we introduced the first prescription for AIDS that tells y'all how old I am. And to think that we now have a medication, because let's do the U equals U again. If I am undetectable, right, I'm
Hmm.
untransmittable. And that so many
Correct.
the um, save for the better, right? And so we want to keep having this conversation. Thank you, Dr. Dyson, for taking the time for us. We know that you are, every time I've emailed her, guys, she's been somewhere in the world. So it's humbling for me that she's here for us. We will have this recording on our YouTube channel. So I encourage everyone on the call, please share this with your village. I appreciate the question from the doula that said, we're always told not to diagnose and not to provide medical care, but I think that the onus is on us as the village to educate. So think about, the minute I find a good hairstylist, I'm telling all my friends, right? The perfect product for your hair, your face, your rings, your jewelry, whatever. We tell our friends, well, let's tell them something that will save their lives. And a bit personal, but after my divorce, and I found out that my husband was unfaithful, I spent 10 years being tested, right? And it's scary. So I would love to save other women from that. And back then, because I've been divorced a long time, back then we didn't know that there wasn't a product that we could take that was a PrEP or that would put us in an undetectable stage. So you're just holding your breath for 10 years. So thank you guys for taking this, joining us for this workshop. We'll send you the recording, send it out to your folks, not judging, but just say, you might need to know this, because as a
Yep.
happily married woman, I would have never known, right? And so things for us to think about. But thank you, Dr. Dyson. Enjoy DC. And then
Yes. Thank you.
National Black Caucus because we got to hear
Yeah.
her first, y'all. So there we go.
Yes, yes. Can I say just one other thing, Marie, on something that you just said about, that uncomfortable or that concern about being a doula, not diagnosing that sort of thing. You mentioned as soon as you hear about a good hairstylist, you would share that, right? Well, what if I told you that one of colleagues has developed a whole curriculum for hairstylists to have this conversation? And so I say that to say that don't let that discourage you that, oh, I don't prescribe or things like that. If we can develop a toolkit for hairstylists and barbers to have this conversation with the clients who are sitting in their chair, then anybody can have this conversation, right? And that's what I want us to take away. Anybody can have a conversation about HIV because, as you said, we go in the beauty shop and we sit there and we say, "Oh, girl, I'm dating this new man." Da, da, da. We talk about those things in there with each other, right? And men talk about it in the barbershop. So, what is the harm in saying, "Well, that's wonderful. I am happy for you, sister. I am happy for you, brother. But do you know your HIV status? Do you know theirs?"
Mhm.
Right?
Yes.
That's a simple conversation, a simple question, right? To get us to at least think about it and to normalize the conversation. So again, anybody can have the conversation. Anybody can educate about HIV and the statistics that you saw, the data that you saw, all of that. So
And there is a toolkit for birth workers and other professionals. So I won't drop it in the chat because then you guys have to scramble and grab it as we're, but I will send it in the email that we always send with the recording. So we'll send that out to you. And I want to challenge you. We go to see our hairstylist, I don't know about y'all, but once a month, right? And so let's ask him or her, were you aware? And we'll carry the link in our little, phone notes or whatever, and give it to them and encourage them. So it takes a village, right? And so we will look to have you back, Dr. Dyson, as your schedule allows. Thank you guys for being here with us. And we will send you the link to ViV Healthcare and the plethora of resources that they have available. You all have a great night. Thank you.
thank you. Take care.